All right, welcome. In our journey through cardiac pathology, we've spent a lot of time on the syndrome of heart failure. Now we're going to dive deeper into the specific diseases of the heart muscle itself, the cardiomyopathies. And having that solid foundation in heart failure is absolutely essential because it gives us the clinical context to really understand the structural and functional problems that define these conditions.
So here's our game plan for this explainer. We're going to tackle this systematically. We'll start with the absolute cornerstone, the formal definition. From there, we'll classify the main types, and then we'll apply that knowledge to a real-world clinical case. We'll also dig into the genetics, review some key acquired causes, and we'll wrap up with a special focus on myocarditis, a condition that's famous for being a diagnostic chameleon.
Okay, first things first. Before we can even begin to pick apart the different types of cardiomyopathies, we have to establish a really precise, universally accepted definition. And trust me, this isn't just some academic exercise. This definition is the fundamental tool for our differential diagnosis. It guides our entire workup.
I love this saying because it's just so true. The definition is the king here. If you apply this definition rigorously, it allows you as a clinician to systematically rule out other things. It's the only logical place to start, and it stops us from mistakenly blaming the heart muscle itself when the real problem lies elsewhere.
Okay, so here it is, the definition. Cardiomyopathy is a myocardial disease where the heart is structurally and functionally abnormal. Now that little word "and" is everything. It's the whole ballgame. Both of these conditions must be met at the same time. For example, think about an elite athlete. They might have a structurally bigger heart. That's a structural change, but its function is perfectly normal, even better than normal. So that's not cardiomyopathy. On the flip side, you could have a condition like long QT syndrome, which causes major functional electrical problems, but the heart muscle structure is totally normal. Again, not a cardiomyopathy.
And this slide highlights the other critical piece of the definition. It's a diagnosis of exclusion. So if a patient's weak heart muscle can be explained by, say, clogged arteries from coronary artery disease, or if their thickened heart wall is a direct result of battling high blood pressure for years, well, then it's not a primary cardiomyopathy. Those are examples of the heart remodeling itself in response to another problem.
Okay, so now that we have that super precise exclusionary definition locked in our minds, we can move on to classifying the primary cardiomyopathies, and we typically group these based on what they look like and how they behave.
The field is really dominated by three main types. You have dilated cardiomyopathy, or DCM, where the heart chambers get big, baggy, and weak. Then there's hypertrophic cardiomyopathy, HCM, where the muscle gets inappropriately thick. And finally, restrictive cardiomyopathy, or RCM, where the walls get stiff and rigid. We're going to focus mostly on DCM because it's the most common, but it's crucial to know about the others, as well as these less common but still very important players like Takotsubo and ARVD.
All right, theory's great, but let's see how this actually plays out in a clinical setting. We're going to walk through a pretty typical presentation of dilated cardiomyopathy. This is the one that's responsible for a huge number of non-ischemic heart failure cases.
So, our case starts with a 25-year-old man. He comes in complaining of being exhausted and tired for about 6 months, and he's also noticed some palpitations. Right away, these are classic symptoms of a low-output heart failure state. The fatigue is from the weak pump, and the palpitations are likely from his body's own adrenaline system kicking into overdrive to compensate.
And when you examine him, the signs are just screaming cardiac decompensation. His heart is racing at 120 beats per minute even while he's just sitting there. You can feel his apical impulse, the point of maximal impulse, has shifted down and out to the side, which is a dead giveaway that the heart is enlarged. His neck veins are bulging, telling you pressures are high on the right side of his heart. And when you listen with a stethoscope, you hear that classic S3 gallop, a sound of blood sloshing into a floppy, overfilled ventricle. It's a hallmark of systolic dysfunction.
And then, the echocardiogram gives us the hard data. This number right here says it all. His left ventricular ejection fraction is only 20%. To put that into perspective, a normal EF is above 50–55%. This is profoundly, severely reduced, and it's the direct reason he's having all these symptoms.
So the echo findings are textbook for DCM. We see a stretched out, thin-walled, baggy left ventricle. The key term here is global hypokinesia, which just means the entire heart muscle is contracting very weakly. In a young guy like this, after we've made sure he doesn't have coronary disease, hypertension, or valve problems, we can confidently make the diagnosis primary dilated cardiomyopathy. So we know what he has. The next huge question is why he has it.
And given his young age, our suspicion for a genetic cause goes way up. We now believe that at least 30% of these idiopathic cases, meaning cases without a clear cause, are actually familial. And honestly, that number is probably going to get even bigger as we get better at genetic testing.
Now, this table summarizes the high-yield genetic links you really need to know. For DCM, the most common culprit by far is a mutation in the titin gene. Titin is this massive protein that acts like a structural spring inside our heart muscle cells. For ARVD, the problem is often in the genes for desmosomes. Think of these as the molecular rivets that hold heart cells together. And for LV noncompaction, a classic association is an X-linked mutation in the tafosine gene.
Now, while genetics are a huge piece of the puzzle, it is so important to remember that a huge proportion of cardiomyopathies are acquired. They're the result of some specific insult, a systemic disease, or an inflammatory process that happens during a person's life. And this just shows you the whole spectrum of key non-genetic causes. You have things like peripartum cardiomyopathy, which is related to the unique stresses of pregnancy. There's direct toxic damage from things like alcohol or certain chemotherapy drugs. You can even see it with nutritional deficiencies or as part of a systemic autoimmune disease. And of course, there's inflammatory cardiomyopathy, or myocarditis, which we're going to treat as its own special category. So here's a crucial takeaway. The prognosis, the likely outcome for the patient, is hugely dependent on the cause. Some of these acquired forms like peripartum and alcoholic cardiomyopathy actually have a pretty good chance of recovery if you can remove the trigger. After delivery or with complete abstinence from alcohol, the heart function can bounce back. But then you have the flip side. Damage from things like anthracycline chemo drugs is often progressive, severe, and irreversible.
Let's wrap up with a deep dive into myocarditis. This one deserves special attention because its clinical presentation is all over the map. It can mimic a ton of other cardiac conditions, which is how it earned the nickname the Great Masquerader.
Think about this classic clinical puzzle. You have a patient with chest pain, their troponin lab test is high, indicating heart muscle damage, but when you take them for a coronary angiogram, their arteries are perfectly clean, wide open. This scenario should immediately make you think beyond a typical heart attack and consider other causes of myocardial injury. And myocarditis should be right at the top of your list. At its core, myocarditis is simply an inflammation of the heart muscle. You get an infiltration of inflammatory cells into the myocardium, which causes direct injury to the heart cells. This inflammation messes with both the electrical and the mechanical function of the heart, and it often presents clinically as a brand new, acute case of inflammatory dilated cardiomyopathy. Now this slide really gets at why it's such a trickster. It can show up in at least 3 very different ways. Sometimes it's subtle. A patient develops new heart failure symptoms a few weeks after having some kind of virus. Other times, it looks exactly like a heart attack, with chest pain and high troponins. And in its most severe form, it can cause a young, otherwise healthy person to present in profound, unexplained cardiogenic shock.
So the essential takeaway here is this. Myocarditis is, at its heart, a clinical diagnosis. Yes, we have incredible imaging tools like cardiac MRI that can show us the inflammation and scarring, but at the end of the day, it's about being a good clinical detective. You have to be able to recognize these different patterns and maintain a high index of suspicion in the right context. That's what leads to a timely diagnosis and allows you to start the supportive care that can be life-saving. It truly is one of cardiology's great masqueraders.